rates. You see here, this chart, there are multiple independent studies show higher failure rates with type 4 bone. Other biomechanical reasons for failure in maxilla is the directional forces against the thin labial cortical bone and offset forces in the maxilla, and in the premaxilla, highest off-axis forces because of angulation. So main reasons for high failure rates of implants in maxilla are low bone density, and increased forces due to the narrow ridge, facial cantilevers, off-axis crown height, and lateral forces during excursions, which all these factors we see in the premaxilla as problems. And conclusion should be place additional implants in maxilla, and minimum 4 implants to 6 or more. 4 to 6 implants for tissue-supported overdentures, 7 to 10 implants for only implant-supported overdentures. Which factors are more important in the maxilla? Implant number, diameter, and length, and which is more important for success? Usually number comes first, and then the diameter, and then the length. We need to use maximum size implants for immediate loading. So 4 implants in this case supplanted with a bar and no tissue support in maxilla. We usually know that 4 implants is not sufficient to support a totally implant-supported prosthesis. So what are the consequences? Flexing in longer bars increases the forces on the implants, and angled implants, such as you see here, lose 20 to 30% of support area. So a maxillary arch may be divided into 5 segments. For proper treatment plan, at least 4 implants must be placed in each 3 segments, and they should be supplanted together to withstand lateral forces. So usually canines are the first choice for placing implants, and the other 2 implants can be placed in the premaxilla or in the posterior maxilla. If in the posterior maxilla, then we should place our implants in the lateral position for square arch form. So I think all of you know this. The implant locations for mandibular overdentures are in the midline, mesial to the canine positions, and between the first and second molar, A and E. There are 5 implant overdentures options exist for the mandible. And for retention, stability, and support is determined by the implant number and position. The more resorbed the bone, the more implants are needed and splinted. So if you have higher bone, you can put less implants and unsplinted. With more resorbed bone, we need to put more implants with a splinted design. 2 implant overdenture existed for the maxilla, which are 4 to 6 implants with some tissue support and 7 to 10 implants with total implant support. And overdenture movements. We can have movements, 0 movement. If the attachments are designed in its angled way, and the axis of rotations for each attachment are these white lines, and this is the midline, and higher stresses on the attachments, superstructure, and the implants will occur in such design. The number 1 problem of O-ring attachments occur because of implant angulation and location. On the left side, is there more proper implant angulation, and on the left side, improper implant angulations. So what are the prosthesis problems when 2 implants are placed in A and E position, distal to the canine position? Denture rotates around the fulcrum, and splinting is not suggested. So, as the denture rotates around the fulcrum, as we see here, we see tissue irritations, such as this. The distal of the incisor edge to the line connecting the ball attachments determines the anterior rotation of the denture. As this distance increases, the rotation of the anterior part increases. So we may need to put another implant in the midline position anterior. Overdenture problems occur when two implants are split in A and E position. Non-axial load on anterior side on cemented bar, loosening of cupping screws. There are 2 times more moment forces on implants, and bar flexes 5 times more comparing to B and D position. When we look at the retention forces of ball attachments, which may be the highest occlusally direct forces on the implants, in the literature, there are between 11 to 37 Newton. And when we compare it with the bar attachment with the second implant, the blue arrow, and the occlusally directed force is about 45 Newton, which is much less than the forces exerted on the ball attachments. So when we have a design like this, and when patient chews on the back side of the mouth, on the denture, the occlusally directed forces are not a major concern for us, but greater rotational movements on the distal implants may be more concern, as you see on this axis. 2 splint implants with a distal cantilever bar is contraindicated because non-axial load on distal side, screw loosening, moment forces on implants occur. This patient came to my office with a screw loosening and received this bar design 3 months ago and was never happy. So, in Overdenture 2 design, the ideal distance between implants should be 14 to 16 millimeter and minimum 10 and maximum 22 millimeters. If you have longer bar, it will flex, and shorter bar will cause stability problem. So why should ball attachments and implants be symmetrical? What happens if ball attachments are not the same height? As you see here, this implant and the ball attachment is in the higher position. It moves upward during mastication, makes more rotation and overload in function. So what we see is more early O-ring problems. Another problem, soft tissue contour problem at implant periphery, plaque accumulation at gingival health. Why? Because of concave contour in the same mouth. This is the convex contour around the implant, the soft tissue contour. This is the bone situation, not only the